Ladies and gentlemen, good morning. It's really my pleasure to be here in Cairo with you to discuss about treatment of metastatic triple-negative breast cancer. I saw that my distinguished colleagues addressed already many topics that I will summarize again in my presentation. So those are my disclosures. So we know very well that treating a metastatic triple-negative breast cancer is like treating an heterogeneous disease. We have several subtypes in clinical practice, and it's quite important to remember that any one of these subtypes is a specific treatment pathway. So I will discuss about BRCA mutant, non-BRCA mutant. I will summarize the data of immunotherapy, and finally I will discuss about antibody-drug conjugate. Triple-negative breast cancer is an heterogeneous disease. We have a spectrum of disease moving from invasive ductal carcinoma high grade to metaplastic low grade. And you would agree with me that treating in the metastatic setting a metaplastic low grade or adenoidocystic carcinoma is completely different from treating an invasive ductal carcinoma high grade. And according to the spectrum of heterogeneity, we have several targets that are potentially actionable in the context of a metastatic triple-negative disease. We have the immune-enriched subtype with the expression of PD-L1, the DNA repair deficiency that are specifically the BRCA mutated, and the PI3 kinase, aka mTOR activated pathway. And finally, we cannot forget also surface antigens like LIB1 and TROP2. Let's start to summarize the data on BRCA mutated. We are discussing about a molecular subtype that is the basal-1 and basal-like 2 triple-negative breast cancer. In most of the cases, we had high P67 and BRCA germinal mutation. If we remember the ABC guidelines, for patients with germinal BRCA mutation, a single-agent PARP inhibitor like olaparib or talazoparib should be considered the preferred treatment option for those with triple-negative advanced breast cancer, because there is an improvement in response rate, in progression-free survival, and in quality of life. Data are coming from two important trials. One is the Olympia-D with olaparib, and the second one is the BRCA with talazoparib. The Olympia-D included patients with triple-negative or ER-positive breast cancer that received less than 2 lines of chemotherapy for metastatic breast cancer that are germinal BRCA mutated. And patients have been randomized 2-to-1 to olaparib versus treatment of physician choice, including capecitabine, eribulin, and vinorelbine. The primary endpoint was progression-free survival. If we look at the final data of the trial, it's quite clear that olaparib improved progression-free survival with respect to treatment of investigator choice, bringing progression-free survival from 4.2 months to 7 months with olaparib. In terms of response rate, that was a secondary endpoint. We had 59% response rate for olaparib arm versus 28% in treatment of investigator choice. The second trial was the BRCA trial. In this trial have been included the patients with HER2-negative breast cancer with germinal BRCA1 and BRCA2 mutation, and the stratification factors was number of prior chemotherapy, triple-negative versus HR-positive, and history of CNS mets. Randomization was 2-to-1 to talazoparib versus physician choice of therapy, including capecitabine, eribulin, gemcitabine, or vinorelbine, and the primary endpoint was progression-free survival. Also, in this case, we have a response rate close to 63%, with 5% complete response and 57% partial response. And in the chemotherapy arm, we have 31% partial response. There is an improvement also in progression-free survival from 5.6 months in the chemotherapy arm to 8.6 months in the talazoparib arm. There is no improvement in overall survival, but there is a statistically significant improvement in quality of life, with the median improvement in quality of life of 26 months in the talazoparib arm versus 6 months in the chemotherapy arm. Also, patient time to deterioration was much more better in talazoparib arm, 26 months versus 15 hours in chemotherapy. It is unknown how a PARP inhibitor compares with platinum compounds in the metastatic setting, and I would like to remind the Tnt Trial presented by Andrew Tutt a few years ago. The Tnt Trial was a prospective randomized trial comparing carboplatin to docetaxel and then crossover in patients with triple-negative breast cancer. And there was also a population included that were patients with BRCA mutation. If we compare in the overall population docetaxel versus carboplatin, in terms of response rate, there is absolutely no difference. 31% response rate in carboplatin, 35% in docetaxel, and also in the crossover arm, results are quite similar. But if we compare the data in the BRCA mutated population, there is an increase in response rate from 33% in the docetaxel arm to 68% in the carboplatin arm, much more concentrated in the frontline treatment. So, we really don't know if it's better to treat those patients with platinum salts or PARP inhibitors, because we will never have results of a trial in the metastatic setting. For non-BRCA mutated associated triple-negative advanced breast cancer, there are no data supporting different or specific chemotherapy recommendations besides platinum, and all chemotherapy recommendations for HER2-negative disease also apply for triple-negative advanced breast cancer. What is quite important is that in the metastatic setting, carboplatin demonstrated efficacy and more favorable toxicity profile with respect to docetaxel. Of course, an option is atezolizumab plus nab-paclitaxel for PD-L1 positive triple-negative breast cancer with de novo, with a 12 months treatment-free interval. And this is the immunomodulatory subtype. I am quite sure Peter Schmidt already presented those data, so I will be very short on this. The inpatient key 130 randomized patients with triple-negative breast cancer and PD-L1 positive by SP142 to atezolizumab plus nab-paclitaxel versus placebo nab-paclitaxel. So those are the characteristics of the patients, many of them with 0-3 site of metastatic disease or more than 4 sites. The number of PD-L1 positive patients was 41%. In the primary progression-free survival analysis in the intent to treat population, there was an improvement in progression-free survival, moving from 5.5 months to 7.2 months. This was a hierarchical statistical design. It demonstrated activity in the co-primary endpoint, progression-free survival and overall survival in the intent to treat population. Then there was an analysis in the PD-L1 positive population. Here, it is confirmed that the result of an improvement in progression-free survival from 5 months in the chemotherapy arm to 7.5 months in the immunocheckpoint arm. Also, overall survival data confirmed the benefit in terms of overall survival from 18 months to 21 months in the intent to treat population, not statistically significant. And in the PD-L1 positive population, this was statistically significant, improving the overall survival from 18 months to 25 months. Data have been presented on inpatient 130 with the final overall survival during ESMO 2020, and we can see here that there is a clear improvement in progression-free survival from 5 months to 7.5 months, and those are the final data in the PD-L1 positive population. The median overall survival was 17 months in the chemotherapy arm, 25 months in the atezolizumab arm. Contrasting results are coming from inpatient 131 presented during ESMO 2020. The trial randomized patients to atezolizumab paclitaxel versus placebo paclitaxel, and here we have no improvement in progression-free survival in the PD-L1 positive population, but also no improvement also in the overall survival. I would like to mention also the Keynote 355 that randomized patients to pembrolizumab plus chemotherapy versus placebo chemotherapy. Here we have 3 different regimens, nab-paclitaxel, paclitaxel, and carbo and gem, and the benefit of progression-free survival was assessed in PD-L1 positive population, is assessed according to the CPS score. Those are the characteristics of the patients. Finally, we have also the novel metastatic disease, 29%, but also patients with a treatment-free interval of less than 12 months, 22%. Those are the data in patients with CPS score more than 10. There was an improvement in progression-free survival from 5.6 months to 9.7 months. And in the CPS score more than 1, there is also a trend in terms of benefit. No data, of course, in overall survival we have, and there is a trend of benefit also in the intent to treat population. Additional analyses have been presented during San Antonio, and it's quite clear that the more you enrich according to CPS score, and the best you achieve also in terms of response rate and duration of response. Those are the data also in subgroups by on-study chemotherapy with nab-paclitaxel, paclitaxel, and carbo-gem. So finally, FDA approved 3 different treatment regimens. We have the Keynote 355. FDA grants accelerated approval for pembrolizumab plus chemotherapy in patients with CPS score more than 10, and the inpatient 130 atezolizumab plus paclitaxel in patients with PD-L1 assessed by SP142 more than 1%. There is, of course, no approval for the combination of atezolizumab plus paclitaxel. So, and those are finally the characteristics of the 3 study. And just to note the differences, the minimum disease-free interval was 6 months in the Keynote 355, different chemotherapy regimens here. Prior chemo for early breast cancer, it was only 22%, with the same class for the Keynote 355. The novel metastatic disease were quite similar, and here the percentage of positivity is quite similar. Moving to another pathway, I would like to mention the PI3 kinase, AKT, Tnt altered triple-negative breast cancer. We had the Tnt Trial recently presented by Rebecca Dent during the San Antonio Breast Cancer meeting. Patients with triple-negative disease that received no prior chemotherapy and with an alteration of the PI3 kinase PTEN-AKT1 pathway have been randomized to paclitaxel plus ipatasertib versus paclitaxel alone, and in the analysis of the final results, there is no improvement in progression-free survival. Similar data have come from Peter's Beat in the PACT study, paclitaxel plus capivasertib versus paclitaxel placebo. Here there was a trend in terms of benefit in the progression-free survival, 12 months versus 19 months, but the difference finally was not confirmed in the final analysis, and the PI3 kinase, AKT-P10, there is no benefit in overall survival. So another trial is ongoing, is the Capitello, phase 3 trial, double-blind, randomized study assessing efficacy and safety of capivasertib plus paclitaxel versus placebo paclitaxel in the first-line setting. And finally, I would like to mention the data of sacituzumab govitecan. It is an antibody-drug conjugate targeting TROP2 with a high drug-to-antibody ratio conjugated with the SN38 payload that is a more potent compound with respect to irinotecan. The Tnt Trial was a phase 3 confirmatory study of sacituzumab govitecan in refractory relapsed metastatic triple-negative breast cancer. There are randomized patients who received 2 or more lines of chemotherapy to sacituzumab govitecan versus treatment of physician choice. And in this case, different chemotherapy regimens were approved, like eribulin, vinorelbine, gemcitabine, or capecitabine. The primary endpoint was progression-free survival. Secondary endpoint was PFS for the full population, overall survival, overall response rate, because in the primary analysis, patients with CNS mets were excluded. What is quite important, 529 patients have been randomized, 267 to sacituzumab govitecan, 262 to treatment of physician choice, including eribulin, capecitabine, gemcitabine, or vinorelbine. Those were the characteristics of the patients. ECOG performance status was 0-1 in the majority of the patients. We had 7 and 8% of patients with BRCA mutation. We have some patients that were also ER positive at the diagnosis and then triple negative in the metastatic setting. The most common previous chemotherapy included in 100% of patients taxane, cyclophosphamide, and also in 63 and 69% of the patients platinum salts. Of interest, 7 and 8% of patients received PARP inhibitor, and 29 and 26% received immunocheckpoint inhibitors. And those are the final data. It's quite interesting. There is an improvement of progression-free survival from 1.7 months to 5.6 months, with an overall benefit that is absolutely the same in all the subpopulation analyzed, including also in patients who received previous immunocheckpoint inhibitors. And the most exciting result is related to the overall survival. We have an improvement, dramatic improvement in overall survival, from 6.7 months to 12 months. Data have been sent to New England Journal of Medicine, and I hope the drug and the data will be published as soon as possible. And sacituzumab govitecan had breakthrough designation approval from FDA. The overall response rate was also impressive, 35% in the sacituzumab govitecan arm versus 5% in the treatment physician choice. Regarding safety, the most common toxicity was neutropenia and anemia, with grade 3 and 4 respectively 46 and 17%, and we had gastrointestinal toxicity, 10% grade 3 and no grade 4 in terms of diarrhea. So this was the first phase 3 study with an antibody-drug conjugated anti-TROP2, demonstrating an improvement in progression-free survival from 1.7 months to 5.6 months in the triple-negative breast cancer, advanced breast cancer population, and an improvement in overall survival from 6.7 months to 12 months. And the safety of the drug was quite good. During San Antonio, some data on TROP2 expression have been presented. It's a very limited subgroup of patients, and it seems we don't have many correlation both with TROP2 expression from both high or with BRCA mutation. And we confirm that FDA grants accelerated approval for sacituzumab govitecan for metastatic triple-negative breast cancer. I would like to mention also now the antibody-drug conjugated that is an entirely one conjugated with aristatin, microtubule disruptors. And here we have an antibody drug conjugated that is ladiratumsumab vedotin. Data is monotherapy in triple negative disease are promising with 25% response rate, but most impressive is the combination with pembrolizumab. You know, the future of antibody drug conjugated can be also to combine them frontline in the PD-L1 positive or negative population together with immunocheckpoint inhibitors. So, many new treatment for advanced triple negative breast cancer, chemotherapy, PARP inhibitors, antibody drug conjugated and immunocheckpoint inhibitors, and also PI3 kinase inhibitors. I believe for the futures, the research priorities will be the following. First, we need for all these agents to evaluate the magnitude of clinical benefit scale in order to understand which are the drugs that give more benefit and less toxicity. We need more efforts to implement the patient-reported outcome. We need a real-life, real-world studies to evaluate effectiveness. And so the future will be to integrate big data, moving from evidence-based to real-world evidence-based medicine. So thank you very much indeed, and I will wait all of you in Berlin for the ESMO breast cancer meeting on May 10 to 12, 2021. Thanks a lot for the invitation.
Thank you, Professor Guissepe, for this nice and elegant presentation. It's really a very interesting topic, and it's, as you had mentioned, it's still an area of intense research. Thank you, Professor Guissepe, for this nice presentation.
Thank you to you for the kind invitation.
Ahmed, can we have a question for Professor Curligiano? Ahmed, can we have a question?
Yeah. So we have a question from the panel. I will pass it if you cannot hear it well, Professor Guissepe.
Okay, yes.
Professor Guissepe, I am Professor Mohammed Yassin, and I have a couple of questions for you. My first question, do you think, as regarding Impassion 131 trial, do you think it was a negative trial because the chemo partner was paclitaxel, and you know in paclitaxel we use corticosteroids as pre-medication? In contrast to Impassion 130 in which we used the nab-paclitaxel without corticosteroids preparation. What's your comment on this finding?
Yes, you know, the Impassion 131, first of all, was a trial designed with a randomization 2-to-1. So the sample size was lower respect to the Impassion 130. And in the statistical design, the hierarchical model was to demonstrate first a positivity in improvement in progression-free survival in PD-L1 positive population, and then in the intent to treat population. As you stated, this is a negative trial, so the only explanation I may have is one, potentially is the combination with paclitaxel for which we are using steroids. Two, the number of patients that have been included with the randomization 2-to-1, that can be a limitation in terms of statistical analysis. But finally, the message is that we cannot combine atezolizumab with paclitaxel, but only with the nab-paclitaxel.
Okay, thank you. Another question. Do you think it is logic to keep targeting the AKT-P10 pathway? We have seen before in cancer prostate from the potential trial that targeting P10 with ipatasertib didn't give us the results we were expecting. And again here in triple negative breast cancer, using ipatasertib also was not with the results we are expecting. So why do you think targeting the AKT-P10 pathway always didn't give us the results we were expecting by targeting this pathway?
This is a very good question, and I thank you very much for asking this. So I really believe that the matter is related to the selection of patients, because all the studies presented finally had a very limited benefit from this combination and a lot of toxicity. I believe we should wait for 2 trials. The first one is the Capitello that is still ongoing, and the second one is the EPIC trial that is going to select patients with triple negative breast cancer according to the PI3 kinase mutational status. And it will be nab-paclitaxel versus nab-paclitaxel plus alpelisib. So potentially, the more you enrich the population according to target alteration, the more you can achieve a better result.
Okay, thank you, Professor Guissepe. Thank you very much.
Thank you, Professor Guissepe. It's really a pleasure that for having this interactive discussion despite of the distance and being virtually and digitalization. So now Professor Nagi Saghir had joined, so we are eager to complete the rest of the picture for the metastatic triple negative breast cancer. So Professor Nagi is a
Hello?
Hello, Professor Nagi, we hear you well.
Where's my presentation?
So,
okay. You see my presentation? Share content, share screen. Share screen. I need to share screen with Zoom. Zoom, where is Zoom? وين هلا كان؟ Yes. Share screen. فيديو ما بتحطيني فيديو؟ Hello.
So,
you hear me?
Hello, Professor Nagi. This is Ahmed Shash. Yes, we hear you very well, and we can see your presentation. So I was just introducing your presence. Professor Nagi Saghir is a well-known figure in the Middle East and all over the world in breast cancer. He's a professor of clinical medicine and the head of division of the hemato-oncology and the director of the breast cancer Center of Excellence at the American University of Beirut Medical Center. Professor Nagi will actually try to complete the rest of the picture about the metastatic triple-negative breast cancer, and he will give us a shed about the BRCA mutations in the metastatic breast cancer. Professor Nagi, we are eager to hear you.
Okay, good morning, everyone. It's really a pleasure to be with you. I'm sorry I miss you all in Cairo. You are really lucky that you don't have a lockdown that we have. And I assume you had a nice trip yesterday to the Nile. My task is to talk to you about BRCA mutations in the metastatic breast cancer. Those are my disclosures. I looked for Dr. Hamdi just sent me his slides, but I didn't have time. Just to give you an idea that triple-negative breast cancer is also important in our part of the world. It does constitute about 10 to 15% of all cases worldwide. And in our part of the world, it is also important. This registry was presented interim, data at San Antonio by Dr. Hamdi Abdelazim. There is a variety of percentage of breast cancer triple negative in Middle East and Africa. I just put some slides that we had from Lebanon. We had several studies that showed that triple negative breast cancer constitutes between 9 and 12% of all cases of breast cancer in Lebanon. This is similar to other Arab and Middle Eastern African countries, but it was a little higher in some other countries. As I said, therefore, 10-15% of all breast cancers. By definition, we have ER negative, PR negative, and HER2 negative. Cytokeratins are expressed in about 70% of these cells. We have expressions of PD-L1 also that we will talk about its importance later on. Those tumors are usually high grade, high proliferative index, high mitotic counts, pure tubular formation, lymphocytic infiltrates. All these things also makes the tumor more immunogenic than others, and that's why we will talk about immunotherapy later on. In general, they have a worse prognosis, these patients worse prognosis. They present at advanced stages, more common in younger women, obese women, African women as well. If it's early, high recurrences within a few years, frequently they recur in the liver and lungs. Now, association with BRCA mutations, 15 to 20% of triple negative breast cancer patients do have BRCA1 mutation. And the BRCA1 mutated patients usually, most commonly, they are triple negative breast cancers. This is just a slide that tells you in the BRCA1 up to 80-90% are ER/PR HER2 negative. Some of them also are not. And when you have a BRCA2 mutation, ER positivity is common, and about 10% of the cases have even HER2 positivity. 5 to 10% only of hereditary breast cancer are due to a mutation that makes the patient prone to develop breast cancer. 50 to 60% of those are BRCAs. The others are the other 50%. There are 15 to 20% familial breast cancer cases. Probably some of them, many of them are, hereditary, but we still do not know the mutations that they might have. And 70 to 80% are sporadic. Mutations occur on a chromosome 17, BRCA1, and chromosome 13 in BRCA2. We're going to talk about BRCA pathogenic mutations, not the variants of unknown significance.